Bu depresif belirtiler hastanın...
Well, these depressive indications will mean that the treatment will be more challenging. Previously, it was said that it would be easier. However, right now, if there is depression, then there will be more pain in treatment, and there will be more relapses, there will be more distortion in functioning, and prognosis will be worse. And what is the prevalence? Although the rates are like 60 or 75%, but in cohort studies, it is the depressive indications are like 20%. And also, just like in major depression, the rate of suicide is around 10%. So we can say that schizophrenic patients commit suicide, attempt suicide, just as much as the depression patients. So, first of all, we have some common etiologic causes, and it can be epiphenomenon. And there are some common genetic factors and common neurotransmitter pathologies. For instance, think about a twin. One sibling may be schizophrenic, and the other sibling has a very high possibility of having depression. And also, schizoaffective cases will make these etiologic relations even more complicated. And also, the depression in schizophrenia can be a psychic reaction to schizophrenia, or it can be a complementary component of schizophrenia. Again, there is something that we should not forget. Sometimes we also may just skip them if we have only one single dimension. There are some secondary cases, secondary events in schizophrenia patients. There can be neoplasm, infection, anemia, endocrine or neurological distortions, or there can be the effects of other drugs like antihypertensives, steroids, antiepileptics, and L-DOPA. And in these patients, they can cause also depressive situations that are iatrogenic. And together with the alcohol use, long-term cannabis use, and also caffeine and nicotine use, which may cause depressive manifestations, and also the cocaine withdrawal cases, which may cause manic manifestations, are seen in these patients. When do we see depression? In some of the patients, we see that in prodromal phase. In 1 out of every 5 schizophrenic patients, the depressive manifestations are seen in the prodromal period. And for instance, one patient goes to a physician, and he goes to another physician. They say, no, you have been administered wrong medications. So, because in the first prodromal phase, we can see these effects as depressive manifestations. And again, there can be psychological effects of a relapse, and also the depression or epiphenomenon can be seen in this schizophrenia phase. Under treatment, the patient may be stable, and if you see suddenly some depressive manifestations, then new relapse can be seen in that patient. So that is a possibility that we should bear in our minds. And also, from psychological aspect, in the prodromal phase, the patient may be detached from the social environment, and also he can just be very concerned with his own body, and this may also cause depressive manifestations. In the first episode phase, what do we see in depression in schizophrenia? If the patient has not used any medication yet, in the first episode we can see some depressive manifestations. In 25% of the patients, depressive manifestations are seen in the first 6 months. Again, the psychosis and depressive manifestations may have common pathologic processes. In addition, there is also another group of patients in which we will see depression is the akinetic depression, that is based on the drugs, based on the akathisia, like restlessness, some lack of joy, and inability to sleep. And also, for instance, some patients call you and say that I cannot fall asleep. And if you increase the antipsychotics, then the depression will increase and you will ease the attempt to suicide. Because most of the time, very typically, we may not see the very common manifestations, symptoms, but only some special tests may reveal them. And the antipsychotic induced dysphoria can also lead to suicide without having any akathisia-like symptoms. So antipsychotics may lead to depressive manifestations, but this is a debated issue. Particularly classical antipsychotics cause more of these cases because they block the dopamine, and the necessary dopamine cycle is completely blocked in these patients. That's why they cause depression. This can be true because we know that dopamine is playing a role in pleasure, the sense of pleasure, and antipsychotics is blocking that system, and it's very natural that we see depressive manifestations in these patients. It's very important in dependent schizophrenia, that is, if the patient has schizophrenia and addiction, then antipsychotic drugs will be withdrawn more easily, because in the addicted patients we cannot use dopamine, and if it is blocked even more by antipsychotics, the patients will feel themselves even worse, and they are going to just stop the drug, and they will try to get rid of that depression. However, when we look at these schizophrenic patients having depression and those not having depression, between the doses of the antipsychotic drugs, there is no significant difference. In 10 or 15% of the patients, we have akinetic depression rate, and in our faculty, we had a thesis, a study, and the rates are similar. How are we treating akinetic depression? We know that particularly if there is a use of high potency drug like haloperidol, lower potency drugs should be selected. It can be chlorpromazine, olanzapine, or we can be biperidine or anticholinergic drugs. Benzodiazepine, beta blockers can be used. However, antidepressants are not needed in these patients because the APCI manifestations are removed, and then the restlessness, lack of joy, etc., these kinds of manifestations will no longer be seen. Another depression type in schizophrenia is the post-psychotic depression. That is, the acute manifestations of schizophrenia are just slowing down and depressive symptoms are seen. The premorbid weak social cohesion. The first episode is seen very implicitly, and there can be a vulnerability for new relapses. In one group of patients, some of the depressive manifestations are seen in the acute period of schizophrenia, and positive schizophrenia signs are corrected, and then these depressive signs are relieved. And psychologically, there is such an approach by the patient. We call this as a waking up experience. In the acute period, you know that by means of delusions, the patient is a very important person on the TV. The people are talking about this, and when he is corrected, then he is an ordinary person, a civil servant working in a tax office, etc. So all the senses that are feeding him are actually no longer there. So these feelings can also play an important role. In the treatment, psychotherapeutic approach should be adopted, and if needed, the low amounts should be started, and then the doses can be increased. However, a possible exacerbation should be in our minds. Another depression is seen in the chronic phase of schizophrenia. Persistent positive manifestations are seen in chronic phase, and this may lead to demoralization and depression. And this is seen in average in 15%. Non-hospitalized stable schizophrenic patients, it is even less, like 9%. Depressive and negative symptoms, manifestations are very similar to each other. It's very difficult to differentiate them. There are two basic manifestations. In schizophrenia, we have the flat effect and flattening of the effect, but in depression there is just a low mood, poor mood. And also in depression we have the biological manifestations like lack of appetite, lack of sleep, etc. But these are more apparent. If in schizophrenic patient we see these biological manifestations, then we can say that he is depressed. However, if in the motor manifestations are seen in the other group of the patients, then we can say that differential diagnosis is more difficult. In chronic phase, of course, first of all, we need to make the correct diagnosis, and these schizoaffective cases should be taken at hand separately. Secondary events should be differentiated, and also the relevant drugs, medications should be used. In this kind of depressions, what kind of treatment approach should we adopt? The antipsychotic dose can be increased. That is, if in the chronic phase the patient has some depressive manifestations, and if the I'm sorry, says the speaker. If these manifestations are seen just since the beginning, and it is one of the symptoms of schizophrenia, in those cases the antipsychotics have antidepressant characteristics, therefore their doses should be increased. We know that we have olanzapine, again we have asenapine, as you know. Asenapine, serotonin 2A and 2C blockade is achieved, and 5-HT1A partial agonism is achieved, and also it is used for depressive indications. It is not licensed in Turkey yet, and just tomorrow in the afternoon we are going to have a satellite symposium on that. Lurasidone is also one of the new agents. It is not licensed in Turkey. It is just being used abroad. It's an antidepressant, and also it has an antipsychotic effect. It's an antipsychotic, and it is a very strong D2 5-H2A antagonist. It's a partial 5-HT1A agonist, and in bipolar depression, in schizophrenia, it can be used together with the other mood stabilizers. We know that the quetiapine is another drug that is used very frequently, and through the norquetiapine, it is causing the alpha-2 receptor blockage, and it is also causing the partial 5-HT1A antagonism, and by means of the serotonin 1A antagonism, it is causing an effect that is similar to SSRIs. And you know that in depressions, in resistant depressions, and in bipolar depressions, we use this drug. In the chronic phase, we see depression, and what should be the approach? Again, the clozapine can be used. We know that it is reducing the feeling of hope, helplessness, and suicide. And also, antidepressant can be added on in resistant repressive cases, particularly SNRI and SSRIs are used in my cases. And we should start with very low doses. Could you please sum up? I use them. I start with very low doses, by the way. ECT. Unfortunately does not cause many changes, and cognitive behavioral therapies are also used. In conclusion, we say that this is a challenging situation. The treatment will not be always promising, and it is not our fault. It is something that is caused by the patient's biology. So I just wanted to present this to you. Thank you very much.